next presenter is Dr. Nikita Dash. She'll be talking on multiple subspecialty management in a complicated cataract surgery. Lesson for the aspiring surgeons.
Very good afternoon, everyone, esteemed judges and everyone present here. Today I'll be talking on multiple subspecialty management in a complicated cataract surgery, lesson for aspiring surgeons. So this is a case report of a 58-year-old female patient with a complicated cataract surgery that required multi-specialty management. She presented to our center after 10 days of left eye cataract surgery with diminution of vision and mild pain. When we examined the patient, there was corneal edema with flare and exudates, and there was a large unsutured temporal wound. But there was no hypopyon, surprisingly. Vision was PL positive, PR inaccurate, and pressures were 7. The chamber was shallow with flare and exudates, and the pupil was sluggishly reacting. So, and when we tried to do a very gentle B scan because there was a large unsutured temporal wound, and it showed a multiple low to moderate echoes suggestive of vitreous exudates. So our provisional diagnosis was a left eye endophthalmitis, and we planned for a pars plana vitrectomy in that eye. First of all, we started with suturing the wound before the PPV. Then, while we were trying to do a PPV, there occurred a hemorrhagic choroidal due to low visibility, and we had to drain it. Then there was difficulty visualizing due to small pupil and corneal edema. So we had to remove the epithelium as well as put in iris hooks in that patient for better visibility. And what did we see? An intraoperative surprise. When we were trying to remove all the inflamed vitreous, we saw a piece of a nucleus entangled in that vitreous. So after that, we had to do a very proper vitrectomy and ensure that we did a PVD induction so that we would be able to remove the nucleus fragments properly. And the nucleus fragments were then removed with the help of a fragmatome, and we checked for all peripheral areas of the retina to see that there were whether there were any breaks, and areas of retinal tears were properly lasered. Then there was a post-operative course. The patient had problems with poor corneal healing, so a cornea specialist were consulted, and we had to place in bandage contact lens in that patient to ensure better healing of the epithelial defect. Then patient later developed filamentary keratitis, which was again managed with lubrication, and from time to time we had to remove the filaments also with forceps for better healing. And finally her BCVA was, it improved to 6/60. And but still there was a poor ocular surface, so we had to prescribe ongoing lubrication in that patient. So it has been discussed that prolonged cataract surgery, vitreous loss, and complications are well-known causes of corneal decompensation. And along with it, poor ocular surface can lead to a delayed epithelial healing in cases of debridement for visualizing purposes. And usually if when we are dealing situations like this or cases like this, which have multiple complications in them, so these kind of cases require a multi-pronged approach with respective subspecialty management. So I would like to conclude that we should always respect our ocular tissues and modify our technique or management accordingly and act in the best interest of the patient. Thank you.
Just wondering, with the B scan, there was no nuclear fragments that could be detected as such?
So actually it was totally like wrapped in that exudates of that vitreous exudates. So I think there might have been spikes, but we could not exactly differentiate it from the vitreous spikes because the entire vitreous was inflamed. So when we started removing the inflamed vitreous layer by layer, it was at one place that the nucleus was stuck. Where we got to see it.
Okay, good.
Thanks.
Good.